Welcome to Raaonline. We'll discuss a topic about thyroid in pregnancy. So we'll start with a case scenario. She's a 23-year-old primigravida. She's 30 weeks gestation and she has just lost 4 pounds during the past 2 months. And she states that her heart feels like it is racing and her resting pulse is 135 beats per minute. There is a noticeable tremor when she holds her arms straight and her eyes remain prominent and protruding, and she is complaining of frequent uterine contractions. So basically what we are dealing with is a hyperthyroid lady with tachycardia, with a hyperdynamic circulation, with proptosis, with tremors, in preterm labor, which can be threatened or established. So we start with thyroid physiology. So why this thyroid is causing so much problems during pregnancy is because thyroid disorders are the commonest endocrine disorders in the women of childbearing age group and pregnancy, and they have a more predisposition in females. So thyroid function during pregnancy is very important for the maternal well-being and the fetal growth development. In fact, the only preventable cause of mental retardation is considered to be thyroxine supplementation in hypothyroid mother. So if you can prevent child mental retardation, the only way is to give thyroxine replacement therapy in the antenatal period during the mother to prevent the fetal goiter or fetal hypothyroidism, because maternal hypothyroidism can lead to fetal hypothyroidism and fetal hypothyroidism can lead to delayed development milestones and mental retardation in the child. So the thyroid function tests which we do commonly include the free T3, free T4 and thyroid stimulating hormones, and that is how we basically do the thyroid profile and diagnose thyroid disorders. Now, so many studies have demonstrated that thyroid hormones are essential for fetal growth and development, and if mother is deficient in thyroid hormones, it can lead to altered or suboptimal pregnancy outcomes. But then, how do we diagnose these thyroid function tests during pregnancy? So there are various modifications which happen to the normal thyroid biochemistry when a lady becomes pregnant. So physiological changes happen gland in pregnancy. The first and the foremost is there is an increased blood flow to the thyroid gland, which leads to thyromegaly of normal pregnancy. So low levels of TSH during the first trimester are due to the stimulatory effect of HCG, which has a structure similar to TSH. So what happens is in the first trimester of pregnancy, if you were to do the TSH, it will be rather low because HCG is high and HCG has got a structure similar to that of TSH. So when we are detecting this high beta HCG in the first trimester, so many times it is associated with thyroid storm. So HCG has got a biochemical and a physiological similarity with TSH. So what happens is physiologically TSH declines little bit in the first trimester. Another thing which is happening in pregnancy is there is an increase in the thyroid binding globulin. Now this happens because of the increased estradiol and altered hepatic glycosylation. So there is an accumulation of thyroid binding globulin in the blood. Thyroid binding globulin increase will lead to an increased total T3 and T4. But however, free T3 and T4 will remain unchanged in pregnancy. So total T3 and T4 will be high because binded forms are high in pregnancy because of the increased level of thyroid binding globulin in pregnancy, which happens because of the estradiol and the decreased hepatic glycosylation. Increased glomerular filtration rate leads to an increase in the urinary iodide excretion in pregnancy. So plasma iodine concentration will be low. So if plasma iodine concentration is low, thyroid hormone production can be impaired during pregnancy. So one is there is low iodine availability to the thyroid. More blood is flowing to the thyroid. Thyroid has to synthesize more T3 and T4 because bind form of T3, T4 is increased. Sometimes there are other associated immune changes in pregnancy, and these immunological thyroid disorders can get exacerbated. So fetal thyroid starts functioning at 12 weeks and there is a small minimal transfer of T3, T4 also happens across the placenta. So the commonest cause of maternal hypothyroidism is iodine deficiency, and autoimmune thyroiditis can be caused due to Hashimoto's thyroiditis or Duchenne thyroiditis, which is a transient or subacute form, and Hashimoto's is a chronic form.